Hello, I am Jan Leifman.
Hi, I'm Gayatri from Ilmenon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Ezra Cohen. Dr. Cohen is the chief of the Division of Hematology Oncology and co-director of the San Diego Center for Precision Immunotherapy. He's also the associate director for clinical science, the co-director of the Solid Tumor Therapeutics Research Program, and the co-director of the Hannah and Mark Glaberman Head and Neck Cancer Center at Moore's Cancer Center at the University of San Diego.
In today's presentation, Dr. Cohen discusses the most recent advancements in immunotherapy for head and neck cancers.
Did you know that Dr. Cohen is a globally renowned researcher who has directed and or participated in many clinical trials, including the Avalon 100, Keynote 040, and Active 8 studies? He co-developed a personalized neoantigen vaccine to boost anti-tumor immune response for head and neck cancers. He's also a global expert in the use of immune checkpoint inhibitors to manage head and neck cancers.
An inspiring pioneer in the field of oncology.
So let's tune in and learn from this global leader.
To you about today is the progress that we made in these malignancies that you've heard a little bit about so far, really over the last, let's say 6 or 7 years. First, as many cancers, we had immunotherapy enter the arena of patients with refractory, recurrent, or metastatic disease. And I'll talk a little bit about some of these trials, Checkmate 141 or Keynote 40. And then immunotherapy was moved into the first-line recurrent or metastatic setting and now forms the standard of care in first-line recurrent or metastatic disease. We'll talk about immunotherapy in locally advanced disease and where I think we need to go and what the data have shown us so far. And eventually, although we won't talk about it today, but hopefully immunotherapy will enter into early stage disease, that is stage 1, stage 2, and then eventually immunotherapy as prevention. And believe it or not, there are prevention trials ongoing right now with immunotherapy, certainly not ready to be called standard of care, but hopefully one day in the future. And then with that in mind, some of the mechanisms that we'll talk about include T-cell modulators and stimulators. Here you see a cartoon of the tumor microenvironment. And we now recognize, of course, that T-cells are a potent part of the immune system, especially CD8 cytotoxic T-cells, but also CD4 and other types of T-cells. We'll talk about mechanisms that address tumor-associated macrophages in head and neck cancer. We understand that tumor-associated macrophages play an important part in the immune regulation of head and neck malignancies, and they have become a target for immunotherapy. And we'll also talk a little bit about tumor vasculature and how modulating the tumor vasculature may, in fact, lead to immune stimulation, or at the very least, CD8 positive T-cell migration into tumors and tumor eradication. So let's talk about first-line recurrent metastatic disease to start. And what we see here are the data from Keynote 48. Keynote 48 was a study that really tested 2 experimental arms. You see at the top, pembrolizumab, an anti-PD-1 antibody, and pembrolizumab with chemotherapy against what used to be the standard of care, that is the extreme regimen of platinum chemotherapy, 5-FU, and cetuximab, an anti-EGFR antibody. Just to put this into perspective, the extreme regimen had been the standard of care for over a decade and was actually the first regimen to demonstrate an improvement in survival in recurrent or metastatic squamous cell carcinoma of the head and neck. So the bar was fairly high for certainly single agent pembrolizumab and even for pembrolizumab in combination with chemotherapy. But sure enough, overall survival was indeed improved. Here you see the population of CPS greater than or equal to 1. We'll talk about what CPS means in just a second. But this is pembrolizumab, single agent, versus the extreme regimen, a triplet regimen. And what you can see is that, in fact, pembrolizumab improved survival with a 2-year survival of about 30% in pembrolizumab-treated patients. Now, CPS greater than or equal to 1 means that this benefit was seen only in patients whose tumors expressed PD-L1. And PD-L1 has become a predictive biomarker for these agents, actually not only in head and neck, but across the board in solid tumors. PD-L1 expression seems to be almost a necessity, some degree of expression, almost a necessity for this type of immunotherapy to be effective. And what really excites us about immunotherapy is what's shown in the bottom graphs here. First, the top tables represent response rate, and you can see that the pembrolizumab therapy alone actually produces a higher response rate, a complete response rate than chemotherapy. If you take the population that expresses high levels of PD-L1, that's the CPS greater than or equal to 20 shown on the left, the complete response rate was 7.5%. But moreover, when you look at patients who did respond, what you see are there is a group of patients who benefit tremendously from these types of therapies. And the duration of response is measured at almost 2 years. This is unprecedented in recurrent or metastatic squamous cell carcinoma of the head and neck, and as you can see, much longer than we saw with the extreme regimen. My apologies, a delivery at my door. Now let's take a look at what pembrolizumab and chemotherapy did. And here, what we see interestingly is that irrespective of PD-L1 expression, we see a benefit from adding pembrolizumab to chemotherapy against the extreme regimen. So when we use chemotherapy with pembrolizumab, PD-L1 expression doesn't seem to matter as much, and that we can talk about the reasons behind that. But now this is approved for all patients, irrespective of PD-L1. Now, what you see is that, in fact, the response rate for pembrolizumab chemotherapy versus extreme is almost identical, very similar, but still the duration of response with the pembrolizumab treated patients is longer than the extreme treated patients. Well, we went from single agent pembrolizumab or pembrolizumab and chemotherapy to a combination of 2 immunotherapy drugs in the recently presented Checkmate 651 trial. Here you see the 2 immunotherapies being tested are nivolumab, also an anti-PD-1 antibody, and ipilimumab, this time combined with an anti-CTLA-4 antibody. This is a combination that has shown efficacy in other cancers such as melanoma, renal cell cancer, and even in non-small cell lung cancer. And so this was being tested now, this doublet immunotherapy against, again, the old standard, the extreme regimen. This was a fairly large trial, almost 1,000 patients, 1-to-1 randomization. And the primary endpoint was overall survival. And here you see the primary endpoint of in all patients on the left hand, and you can see that, in fact, the nivolumab and ipilimumab did not demonstrate superiority compared to the extreme regimen. And again, we can talk about the reasons behind that. But interestingly enough, when you look at a population that expresses, their tumors express PD-L1, that is the PD-L1 CPS greater than or equal to 20 shown on the right, you begin to emerge a benefit for immunotherapy now with a hazard ratio of 0.78 and a p-value of 0.05. But moreover, let's look at the duration of response in those patients. And I think this is remarkable. I'll draw your attention to the right-hand curve. And what we see is the duration, first of all, the overall response rate in patients whose tumors express PD-L1 was the same as the extreme regimen at about 35%. The complete response rate was 12%. But look at that duration of response. The median duration of response 32 months, almost 3 years with this doublet immunotherapy regimen. Now, because the trial overall was negative, this is not yet an approved regimen for squamous cell carcinoma of the head and neck. But again, I'm struck by the numbers and the efficacy data in that CPS greater than or equal to 20 population. I'll leave the first line discussion with one more trial, and this is a study that we did at our institution in collaboration with the University of Michigan, UCLA, and Washington University, combining pembrolizumab with cetuximab. So two antibodies, one targeting PD-1 and the other one targeting EGFR, each with their own immune properties. Cetuximab does activate part of the immune system, and the primary response rate here was, the primary endpoint here was response rate. And what we saw with this combination, again, I think fairly remarkable, an objective response rate of 45%, almost half the patients achieved a RECIST-defined response. And since these data were released, two other studies have been reported, essentially using the same mechanisms. One of the trials using nivolumab, one of the trials using a different EGFR inhibitor, but both of those other studies demonstrating response rates in the range of about 40%, 40 to 50%, suggesting that this is real, this was not a fluke of a single study, and that this combination, in fact, does have merit to go forward. What about future combinations, looking at going forward? I told you we talk a little bit about the vasculature and how to influence that. And here's a combination trial of pembrolizumab and lenvatinib. Lenvatinib, of course, is a small molecule inhibitor against VEGF receptor. And what you saw here was in the head and neck cancer cohort, a response rate of just over 40%, which again would be much more than we would expect with pembrolizumab alone, exactly 46%. And what's more is that none of the head and neck cancer patients actually had progressive disease at first assessment, suggesting that in fact lenvatinib can augment the activity of anti-PD-1 antibodies. And as you might guess, this is being taken forward into a phase 3 study. Here you see pembrolizumab now is the control arm, because that is now the standard of care in patients whose tumors express some level of PD-L1, and the experimental arm is pembrolizumab and lenvatinib. This study should actually finish accrual fairly soon, certainly this year, and I wouldn't be surprised if we saw data in about 12 to 18 months. I also told you we talk about macrophages, and here's an agent that specifically targets macrophages, ALX148, or the new name for it is evorpacept. This is an anti-CD47 antibody. CD47 is the don't eat me signal to macrophages, and it inhibits macrophage phagocytosis. And so if you block CD47, you stimulate macrophages to engulf tumor cells, especially tumor cells where an immune response has been formed. And when we combine this drug with pembrolizumab, we saw a response rate of 40% and a 22-month median overall survival. And so this was taken into randomized studies. You see the top trial, ASPEN-03, combining ALX148 with pembrolizumab versus pembrolizumab alone. And then the bottom, ALX148, pembrolizumab and chemotherapy versus pembrolizumab and chemotherapy alone. And these trials are actively accruing. Again, hope to finish accrual sometime this year. So now let's go to second line recurrent or metastatic disease. And we can see first some older data now. I think we can consider this older data. These studies have been around now for about 2 to 3 years, actually a little bit longer than that. The first trial was Checkmate 141. And this is, in fact, actually the first study to show efficacy of immunotherapy in head and neck cancer. The drug was nivolumab, an anti-PD-1 antibody. The control arm was either methotrexate, docetaxel, or cetuximab, investigator's choice. And what we saw was an improvement in survival in these patients who were now refractory to platinum. And what's really remarkable is as we continue to follow the data long term, we do begin to see a tail on the curve, somewhere around 10 to 15% of patients who are surviving long-term on these agents. Of course, we'd like that to be higher, and we've talked about some of the strategies to hopefully make that higher. But the fact is, it's not zero. What happens with immunotherapy is that there are patients who are long-term survivals, despite the fact that they had recurrent or metastatic disease. The second similar study was the so-called Keynote 40. You can see that the design was very similar. Platinum refractory patients. This time the immunotherapy is pembrolizumab. The control arm is methotrexate, docetaxel, or cetuximab, investigator's choice. And once again, we saw an improvement in survival of this anti-PD-1 antibody versus standard of care. And once again, we begin to see the strong suggestion, that there's a tail on this curve. But where are we moving in second line? Here's a very interesting agent. It's a receptor on natural killer cells as the target, NKG2A. This is an inhibitory receptor for natural killer cells and somewhat on T cells. And so the antibody relieves that inhibition, allows the natural killer cells to activate, and in combination with an IgG1 antibody, such as cetuximab, what the investigators saw was a response rate of about 20%. And these are patients who are refractory to both platinum and an anti-PD-1. So these were patients that were already refractory, their tumors were already refractory to immunotherapy and the best drugs that we have, and still the response rate was 20%. And as you might guess, this is now in a phase 3 trial, the so-called Interlink-1 study that combines monalizumab with cetuximab versus cetuximab alone in patients whose tumors are refractory to both platinum and an anti-PD-1 antibody. And again, we hope to see these data in about 12 to maybe 18 months. Well, we've talked about recurrent or metastatic disease. And I told you at the beginning of the talk that the paradigm in oncology, as many of you know, is that if a drug works in the most refractory patients, well, let's take it up front to patients who are being treated for cure. And the thing about head and neck cancer is that the great majority of our patients will present with locally advanced disease, and we will be discussing cure with them. And so it's very exciting for us when we can introduce a new class of drugs into the locally advanced setting, because now we're not talking about patients who might live a few months longer, or in the case of anti-PD-1 antibodies, a group of patients who may actually be cured, but that group is still small. We're talking about now patients who are being treated for cure, and we can augment that cure rate, hopefully markedly and tremendously. And so there was a lot of excitement about bringing these agents forward into the locally advanced setting. And the first experiment to do that was the so-called Javelin Head and Neck 100 trial. This was a fairly simple design. The control arm that you see at the bottom has been the standard of care in locally advanced head and neck cancer for, I'm not even exaggerating, about almost 30 years, about 25 years. It's cisplatin given in high dose, combined with radiation. And despite attempts to improve on cisplatin radiation over the last 2 decades in head and neck cancer, this remains the standard of care. And so the design was to add this immunotherapy drug, an anti-PD-L1 antibody called avelumab, to cisplatin radiation. The avelumab was started 1 week prior. It was added to chemotherapy radiation, and it was continued as maintenance for an additional 12 months. The primary endpoint was progression-free survival. I'll draw your attention to the fact that this was a high-risk population. These were patients with T4 disease, with advanced nodal stage, and these were really the patients at most risk for their cancer coming back. But the trial was negative. Here you see the primary endpoint, progression-free survival, and the addition of avelumab did not improve progression-free survival when added to chemotherapy radiation. In fact, the trial was stopped at interim analysis for futility because the Data and Safety Monitoring Committee felt that the primary endpoint would not be reached when they looked at the data at interim analysis. And you can see, in fact, that the blue arm, this is the avelumab-containing arm, actually is lower than placebo. The hazard ratio is going in the wrong direction. It's 1.2, suggesting that there may actually even be some antagonism when this drug is added to chemotherapy radiation. We can talk about that in the question and answer if there's interest. Overall survival also not improved with avelumab added to chemotherapy radiation. And then we have another study of pembrolizumab and radiation, so anti-PD-1 and radiation, and this in a patient population that was felt to be unfit for cisplatin. So this is now a comparison of cetuximab radiation, which has been a standard of care in these patients for about 15 years, compared to pembrolizumab radiation in an effort to try and improve survival in these patients who, again, were unfit to receive high-dose cisplatin. And what we saw here was, again, a no improvement in the primary endpoint. The primary endpoint was local regional control, and you can see that pembrolizumab did not improve local regional control compared to cetuximab radiation, no improvement in progression-free survival, and no improvement in overall survival. So we have two studies now, randomized trials, in locally advanced disease with attempts to simply add an anti-PD-L1 or an anti-PD-1 antibody to standard of care in locally advanced squamous cell carcinoma of the head and neck, and both studies did not meet their primary endpoint. There are other studies that are yet to report. Here's a trial using pembrolizumab in the neoadjuvant setting, so prior to surgery, and then adding it to standard of care after surgery. This is still accruing. And here's a study using a different anti-PD-L1 antibody, atezolizumab, in the truly adjuvant setting. These are patients who have completed curative intent therapy and then are randomized to either atezolizumab or placebo, with the primary endpoint being event-free survival. And so the chapter is not over for adding anti-PD-1 or anti-PD-L1 to standard of care in locally advanced disease. But so far, we have not seen positive data. And of course, that begs the question, why are these agents that were so successful in the recurrent metastatic setting, improving survival, not being seen, that some improvements not being seen in the locally advanced setting? And again, we can talk about that in the question and answer period. So I'll leave you with a few thoughts. I think first, there are multiple ongoing randomized studies in both locally advanced and recurrent head and neck squamous cell carcinoma that promise to change the standard of care over the next few years. Certainly, I think in recurrent metastatic disease, in the next 2 or 3 years, we will have a new standard of care in head and neck cancer. In addition to that, there are various mechanisms of action that open the possibility for even more potent efficacy through combinations. I've showed you a IO doublet, immunotherapy doublet with nivolumab and ipilimumab. I've shown you some early data with other doublets. But as we use our imagination and we combine these immune mechanisms, we can begin to think about triplets or even quadruplets. Of course, cost will be an issue, but I think what we will end up seeing is a continued improvement in survival and cure rates, even in patients who we thought had terminal diseases that were incurable. And so I'll leave you with a famous quote from Betty Davis from a movie called All About Eve: "Fasten your seatbelts. It's going to be a bumpy night." And I think we will see a lot of very interesting developments in head and neck cancer in the very near term. It's an exciting part. It's an exciting time to be a researcher in this field. So thank you again for the invitation. Thank you for your attention.